Yeah, thank you. At the outset, I would like to thank AIOS for giving me this platform to present this ray tracing aberrometry for corneal and lens-based refractive surgeries. So what is iTrace? Is it a missing piece in ophthalmological practice? Is it indispensable tool for a cataract or a refractive surgeon? And some real-world application with some case scenarios. This is how the iTrace looks like. It is actually a 5-in-1 system which provides auto-refraction, corneal topography, ray tracing aberrometry, pupillometry as well as autokeratometry. So the principle behind is that it sends a laser beam of 655 nanometer through the pupil and measures the exact location where it reaches the retina by using retro-reflected light captured by some reference linear sensors. So 64 such beams are projected sequentially 4 times at different locations on the retina, a total of 256 points, and the retinal positions of all these rays are mapped, forming a retinal spot diagram, and a wavefront is constructed by emergent rays from them. Thus, deviation of those emergent wavefront from that what is entering the eye gives results to ocular aberrations. So let's come to some case-based scenarios, that is the applications of iTrace in lens-based surgery. I'll be discussing subsequently with some cases. Does the patient needs cataract surgery? Preoperative planning of cataract surgery, especially the EDOF and the multifocal IOLs, assessing the visual outcomes in terms of contrast sensitivity, and can we see the optimization or optimizing the results of cataract surgery using the depth of focus curve. This is a major wavefront map display in which total ocular aberrations are depicted in microns. The green are for the lesser or no aberrometric error, and the warmer colors depict advanced aberrometric errors. This is actually an objective documentation of the visual symptoms reported by the patient. So the iTrace beautifully gives us the objective quality of vision as is seen by this map. Another interesting map which iTrace tells us is about the actual ocular aberrations. It is the only instrument which actually dissociates the corneal from the internal aberrations. So it also gives us quantitative measurement of the ocular aberration up to 6th order of aberrations, and we can see this through this map. Coming to scenario 1, does the patient needs cataract surgery? A 42-year-old patient presented with diminution of vision. On refraction, the vision was 6/6. But he said, hey doc, my quality of vision is really deteriorating. So when we did the iTrace, we can easily see that the internal aberrations are contributing to the decrease in vision. So this is an entity called the dysfunctional lens index, which is actually based on the lens opacities, maybe they are cortical or nuclear changes, and it also depends on the aberration profile of the lens. So coming to choosing an IOL based on iTrace, is the patient a good candidate for a multifocal lens? So this was a 52-year-old male, accountant by profession, and he wanted complete spectacle independence. Of course, as we can see on the iTrace, the internal aberrations are more, the dysfunctional lens index is gone down. So less than 5 is an indication of cataract surgery. It is actually not performing that well. And the same is seen as a decrease in contrast sensitivity. So the iTrace is dissociating the corneal contrast sensitivity from the lenticular contrast sensitivity or the internal aberrations. So the MTF because of the lens has decreased. And the same is depicted by the internal higher order aberrations, internal aberrations. So the corneal aberrations are very less, and because of the cataract, the internal aberrations have increased, which is contributing to the total eye quality of vision. The same thing can objectively be defined by a Strehel ratio. So what is Strehel ratio? It is the ratio of the peak height of the point spread function being measured to the peak height of a perfect optical system. So in this map here we get the Strehel ratio. The closer it is to 1, it is actually a perfect optical system. So coming to the very important map which the iTrace shows us is the IOL selection analysis. Whenever we have to plan for a multifocal IOL, we have to keep 2 things in mind. First is about the angle alpha, and second is about the total corneal higher order aberration. So this is the comprehensive map which the iTrace tells us, that is the IOL selection analysis. And the right side of this map, there's a checklist. So it gives us that are the corneal higher order aberrations present, are internal higher order aberrations present, and at the end, it tells us which lens should be considered. Along with this, it also tells us the corneal spherical aberration. So different IOLs, as we know, have different spherical aberration. And if the cornea has a positive spherical aberration, we should plan a IOL with a negative spherical aberration so that we have a residual positive spherical aberration with a good depth of focus. Thus, for this patient, we can see here that the corneal spherical aberration is plus 0.29. So, we can plan a lens, no financial disclosures, but we can still plan a lens with the Alcon lens, which has a negative spherical aberration, leaving a residual positive spherical aberration to have a depth of focus. Thus, the iTrace is giving us an idea that we can plan a multifocal lens for this patient. Also, a total astigmatism, which is seen here, is less than 1. So, it is also suggesting us a monofocal, non-toric IOL. Coming to post-operative quality of vision, we can see beautifully in this map that after the surgery, cataract surgery, the internal aberrations have gone, the DLI has improved to 10. Similarly, with the internal aberrations, you can see that quantitatively the aberrations have gone down, and the MTF has drastically improved. Now, I would like to just spend some time on this slide. This is actually a depth of focus curve. If we omit this pink line and we only focus on this blue curve, you can see that the height of this mountain depicts the best vision. That is, if the patient has a minus 0.45 correction, he'll have the best vision. 50% uphill of this mountain is the usable vision. So, for the right eye, after cataract surgery, this thing, which is written in blue, depth of focus, is for the right eye, 1.43. If we want to give the patient the best outcome, that is a continuous range of vision, we need to place the other depth of focus curve exactly when it is bisecting 50% of the blue line. Like in this picture, as you can see here in this map, this pink line is cutting this blue curve exactly, approximately around 50%. So these two curves have to be placed correctly for a continuous range of vision, and there should be no gap in between so that the patient has an excellent outcome. So especially patients which we are planning for EDOF lenses or multifocal lenses, this depth of focus curve is very useful in giving optimal outcomes to the patient. Coming to scenario 3, a 24-year-old female patient presented with diminution of vision right eye since 4 years. As we can see in the anterior segment picture, there's slight bulge in the posterior capsule, which we can very nicely see in the retroillumination picture. This is a oil droplet reflex. And the anterior segment OCT, we can see a nice bulge in the posterior capsule, suggesting of posterior lentigonus. So what does the iTrace tell us? The iTrace tells us that the dysfunctional lens index has gone down. So any abnormal shape of the lens will also cause a decrease in the dysfunctional lens index. The patient might not have a cataract, but still have a very low DLI, suggesting that cataract surgery would definitely improve the visual outcomes. Similarly, the MTF, because of the internal thing, has gone down, and the DLI is, of course, less. The magnitude of higher order the aberrations because of the internal thing are very high, as we can see in this map. So post-operatively, we placed an IOL in the bag, and it was actually centered. Post-operative, what we can see here, the iTrace is showing us that the visual quality has improved, suggesting that patient did need a cataract surgery. Sometimes it is very important tool to make the patient understand that will the patient improve after cataract surgery, or the patient will have a high amount of residual amblyopia. Post-operatively, we can see after the surgery, the MTF has improved, and the higher order aberrations because of the internal aberrations, they have completely gone. So this new era of patient expectation, like 2020 patient, unhappy patient, is unacceptable in the 21st century, because cataract surgery is now a refractive surgery, and the future is quality of vision, and this quality of vision can be achieved by using this gadget called the iTrace. Thank you.
Well, thank you, Dr. Anchal, and I think Dr. Anchal has very expertly addressed all the points. Important to understand is that this is a gadget which helps the ophthalmologist to understand what the patient is complaining about, and also it helps us to explain to the patient what's wrong with his eye. And especially this concerns the cataract surgery. I had a patient of mine who came, he'd got a CT scan done, he had diplopia, I went to a squint specialist, everywhere, nothing. So then we did an iTrace and it showed that diplopia, it showed a DLI value which was significant, and we went ahead, operated, and it went away. So I think it's an excellent gadget. Any questions from the panel for Dr. Anchal, please?
Yeah, so Dr. Anchal, could you like explain a little bit again once how the depth of focus, how you would use that to, like once you've done cataract surgery for one eye, then how do you do it for the other eye now?
Yeah, actually the depth of focus is another way to plan monovision or a mini monovision. So once we plan a cataract surgery, we make the dominant, we operate the dominant eye first, and we try to achieve maybe plano or maybe a slight minus. And after the cataract surgery, we should look at the depth of focus curve using the iTrace, and then plan the other eye cataract surgery, how much residual myopia we need to leave for the other eye, so that we have a continuous range of vision when the patient is using both the eyes. Especially with the EDOF lenses and the multifocal lenses coming up, this depth of focus curve can actually extend the range of vision.
Dr. Anchal, congratulations. It was a wonderful talk. My question is a follow-up question to Jintan ma'am's question. Do you rely on the subjective defocus values at the same time the patient's refraction, primary refraction of one eye which is operated, and then refer to the iTrace, or it's like which one is more reliable, which parameter is more reliable to stick on?
This is a very good question. The subjective depth of focus is actually more than the objective depth of focus which the iTrace gives us. So even if we plan according to the iTrace, we'll end up landing a more continuous range of vision, because the subjective depth of focus will be much larger than what the iTrace is showing us. But definitely we can plan it, because objectification can be done using the iTrace.